Hello, everyone, and welcome to part one of episode 5 of the Moving Science podcast, focused on advancing health equity in multiple sclerosis care. I'm Quita Highsmith, Vice President and Chief Diversity Officer at Genentech, and today I'm joined by someone who is considered one of the top subject matter experts with over 15 years of experience in neurology, multiple sclerosis, and health disparities, the one and only Dr. Mitzi Williams. Dr. Williams is a board certified neurologist, receiving her Doctor of Medicine degree from Morehouse School of Medicine and completed her fellowship, becoming a multiple sclerosis specialist at Georgia Health Science University, where she received numerous accolades and served as chief resident of the neurology residency program. Currently, she serves as the founder and CEO of her Multiple Sclerosis Center in Smyrna, Georgia, and has served as a founding member since 2018 of the Genentech External Council for Advancing Inclusive Research. Dr. Williams, thank you so much for being here today. To kick us off, you started your Multiple Sclerosis Center back in 2021 during the height of the pandemic. Will you tell us a bit about your career and what prompted you to start your MS Center?
First of all, thank you for such a warm introduction, Quita. Always a pleasure to talk to you and to share a little bit about my journey in this work focused on multiple sclerosis and, of course, health equity. So, I worked in a variety of settings after I graduated from fellowship, including academic centers, and then I went on to work for a very large private practice MS center. And as I got further along in my career, I realized that I really wanted to focus on patient education as well as health equity initiatives. And with my growing family and other, competing interests, I couldn't really do that in the setting that I was in. And so I decided to launch out on my own, which certainly was quite an interesting journey after the pandemic or in the middle of the pandemic. But fortunately, my center has continued to grow and it allows me the flexibility to focus on many initiatives that are really important and that I'm passionate about, such as the work of the Advancing Inclusive Research External Council.
And so, maybe tell us a little bit about what drives your commitment to improve health equity and MS management.
It really spurs from a couple of different things, including a desire to really educate people. The longer I was in practice, I realized that a lot of people didn't really understand the basics of what MS was, the reasons behind what their treatment is supposed to do. And they had MS, some of them for 10 or 20 years. And so, it really came out of this desire and commitment to educate. And then on top of that, I began to see differences in what I was taught in my textbooks and during my fellowship training and what I actually saw in the real world. So we always learned that MS was a disease of young Northern European women. When I walked in my lobby in Augusta and later in Atlanta, at least half or more of my patients were Black and African American women. And so it was really this curiosity to try to better understand why I was seeing so much disease in these populations that we were told didn't get MS, and then also why some of those outcomes that I was seeing in the clinic setting were worse than what I was seeing in other groups. And so that is what really drives that passion. It's really a scientific curiosity, but also a desire to see people educated and overall to see people doing well.
Yeah. Speaking of real world patients, can you elaborate about existing disparities in MS care where you were saying, you walked into the waiting room and you saw these Black and Hispanic patients and it has taken them years to actually get the diagnosis. And so, potentially they have worse disease. Tell us about that.
Yeah, so it's very interesting. So, like I said, when I started my career, we had this kind of picture or face of what MS looked like. It did not look like the faces that I saw in my lobby. And as a result, I began to try to do research to better understand MS in these populations. And then on top of that, sometimes I'd be asked to give a lecture about MS in the Black community for Black History Month by one of our advocacy organizations. And I remember the first time I tried to do a literature search to understand MS in the Black population, I literally could print out every article written about the subject and put it in one 3-ring binder. That was all that we had, and I could read that multiple times throughout the course of the year, that whole binder, to refresh my memory about the data, and so there really was not a lot of information, but the information we did have consistently suggested that Black and Hispanic populations tended to do worse, tended to have more disability, tended to, not do as well on some of our medications. And then when we would look to our clinical trial data, which is really what we consider our gold standard to understand disease process, et cetera, there were no Black and Hispanic people in the trials, right? So some of our early trials, they didn't ask about other populations. And many of our even more recent trials are maybe 10 people, 20 people, 30 people, and you can't make a generalization of that low number of people. And so it really, I really tried to understand, and we still have some gaps we need to fill to better understand why we see worse outcomes in some of these populations. And if it is more a biologic difference, maybe something small that may be biological, or if it's more what we call social determinants of health, right? So those factors that affect your access to getting to the doctor, getting to a specialist, getting medications, et cetera.
Let me just go back a second.
Mhm.
What made you want to become a neurologist? Because what percent of Black physicians are neurologists?
They're not very many. So 2% of physicians, period, are Black women, and a very small number of those are neurologists. What really interested me in becoming a neurologist is that I love the brain. From college, I had a class called Drugs and Behavior. And in that class, although there were talks, some people were really curious about drugs, I was a little bit more curious about the behavior. And so it really taught us a lot about the brain. And I became fascinated with the brain and the central nervous system because to me, it's very logical and makes sense. So I look at my job kind of as detective work, so I look at a problem and then I search the clues back to figure out what caused the problem. So I fancy myself a little bit of a Sherlock Holmes, so to speak. But that is what really got me interested in neurology and then in particular multiple sclerosis because when I started practicing, it was at a time where treatments were first becoming available. And I love the idea that I could help this population, that there are things we could do that could really make a difference. And that has only exponentially improved over the course of my career.
You know what? You mentioned social determinants of health.
Mhm.
Let's talk about that a little bit
Yeah.
because I think for patients of color, if you've got great health care insurance, then life is better for you. But if you've been historically marginalized, you don't have access to health medical benefits, or you might have high copays. You don't have access to fresh foods because you got the corner store. Red line neighborhoods, oftentimes don't have medical facilities or pharmacies. There's transportation challenges. Patients don't have time off of work to go, and the financial burden is high. And so when you are seeing your patient population, how do you think about some of these social determinants to ensure that they get the proper treatment?
Yeah. Excellent question. I think the first piece is recognizing that social determinants in some cases can have more of an impact on outcomes than the medicine you take. So if you take a good medicine, but all these other factors are negatively impacting your health, you can still have really bad outcomes. And so I think, for me, it really is a matter of getting to know patients and asking. I remember a time where people would label certain populations as non compliant, right? This person just isn't doing what they're supposed to do, but never really looking under the surface to understand, okay, well, maybe there's an issue. They can't get here, or they don't have money to pay for parking, or, they don't have, if they have to choose between blood pressure medicine and, getting this copay for this appointment, they may choose the other medicine. If they have to choose between groceries and, coming to this appointment, they're going to choose groceries. And so I think that we have to ask. I think we have to get back to the art of medicine where we really do find out about the people that we're serving so that we can figure out how to best serve them. And of course, it's difficult as a healthcare provider. I can't, physically provide housing for my patients, but what I can do is try to find resources in our local community so that I can direct them to those resources or direct them to the appropriate foundations or other local organizations that may be able to help decrease some of that burden. So social determinants are extremely important. I think that we're just scratching the surface of really trying to address these in the clinic setting. But the first step is that you have to ask, right? So if someone is not following through with the plan, we have to ask, what are those barriers that are keeping you, from following through with whatever treatment plan or whatever plan we come up with? And then are there ways that we can help address those through local resources or national resources?
And so, can you elaborate about the existing disparities you've seen, heard about, been dealing with in multiple sclerosis care?
Yeah. So, first of all, I always like to say there are multiple underserved populations, right? Not just in multiple sclerosis, but across all of healthcare. So, when we think about underserved, oftentimes race and ethnicity might be the first thing top of mind. And certainly these groups, particularly in the United States, are very underserved, but there are multiple populations, rural populations, where they physically may not be able to get to the doctor or physically may have a limited number of neurologists who can treat chronic conditions like multiple sclerosis. We also have our LGBTQ plus population. There are certainly unique areas and barriers to care there. For MS, we have our pediatric population, which has very limited treatment and understanding, as well as our older population. Now, for the purposes of MS and our clinical trials, older is 55 or older, but I'm always very clear that 55 is not old, it's not elderly. But we don't understand what happens with our treatments over time in people over the age of 55 because that's the cutoff for our clinical research. So there are many groups that need additional attention for us to better understand how to treat. And when we better understand how to treat one group, it really helps everyone. But for the purpose of, let's say, underrepresented minority groups here in the United States, certainly there are many factors that lead to certain disparities. So, what we know from the literature is that, particularly for Black and Hispanic populations, they tend to have more disability earlier on in disease. They have poorer outcomes in terms of treatment response. For instance, Black individuals may be less likely to start it on high efficacy therapy early on in the course of their MS. And so there's some very real issues that affect disability level that we I won't say we should not, but we hope to not be seeing in an era where we have very effective treatments. And we know that if we get people on them early, we can prevent disability and they can do really well. So these are things that really need to be addressed urgently and certainly need to be addressed by multiple stakeholders, including, the scientific community as well as our industry partners.
Yeah. And speaking of that, why is it that you think that some communities don't get access to high efficacy treatment?
Yeah, so that is an excellent question. I think there are multiple factors. I think certainly there are patient factors in terms of there are certain diseases that people are very aware of in communities. For instance, I'm a member of the African American community. Everybody knows about high blood pressure. Everybody knows about heart disease. Everybody knows about diabetes. There are certain things that we have acronyms for, and many of our organizations have done a lot of great education in the community. Multiple sclerosis is not as well known in certain communities, again, primarily because we in the scientific community had a picture of what MS looked like, and it didn't look like Black and brown people. And so I think there's really a need for awareness of the symptoms because sometimes the symptoms go away and can be attributed to other things. And really, a lot of education is needed about self advocacy. If you're having issues and you're not getting the answers that you need or appropriate care, having that agency to go somewhere else to seek care is extremely important. I think also there's a need for education in the scientific community. I think that myth of what MS looks like is still pervasive in many people who are still practicing today. I think that it's not completely eliminated from our learning process. And so I think there's really a need to push to make sure that people are looking for this, not just neurologists, but also our primary care physicians, our ER docs, because they are often the first people that encounter these patients. And so, we need to educate our primary care and first line physicians about the fact that MS does occur in many different groups and many different populations, and we need to be looking for it.
One of the things that we did in 2021, we did a health equity study looking at over 2,000 patients in the US, 1,000 from the general population, 1,200 that identified as medically disenfranchised, meaning they belong to either Black, Latinx, LGBTQ, or low socioeconomic status, meaning they made less than $30,000 a year. And the vast majority of the medically disenfranchised said that they felt like the healthcare system was rigged against them and that the healthcare system did not act in their best interest. And so, how do we overcome disenfranchised communities really being able to trust the healthcare system? And we all know about some of the egregious behavior that has taken place in clinical research, whether it was the U.S. Public Health Service syphilis study at Tuskegee, the contraceptive trials in Puerto Rico, where those women did not know they were being given birth control. Like, how do we help patients get over some of these past things so that they can trust the healthcare system?
Yeah, so that's a big one, right? It's something that's not going to happen overnight. It is something that will take a lot of effort from many different stakeholders. I think the first place to start is just kind of taking a step back. And so the way that I describe it to my patients, and the way that I describe it to, different advocacy groups or others that I work with is that, we can be very good at doing research. For instance, if we have, let's say, a hairstylist and that hairstylist does a really bad job, we won't go back to that hairstylist, right? But even though they did a bad job, it doesn't mean we're never going to get our hair done again, right? And so I encourage people to kind of look at it. Although your health is much more, well, your hair is important, but your health is much more important than that. I encourage people to look at it with that lens, right? Yes, it can be discouraging. You may meet people that, may be dismissive. You may meet people that are not, very attentive to the symptoms, or maybe are not doing the appropriate workup. But don't give up, right? So I think there's a lot of work that needs to be done in terms of educating the community. Don't give up, right? This is your health. This is really important. And just like we would try until we find the right fit, for a hairstylist or a mechanic or a car, we will call our friends. We will reach out to our contacts. We will ask everybody who's the best person. I think we sometimes need to take that approach to healthcare and have this expectation that if we go that one time, that's going to be the perfect answer. And, if it doesn't work out for us, we're just going to quit or give up. I think the other piece is that we need more diverse healthcare providers. Now, that's something that will take a little bit longer time, but people do feel comfortable with people who look like them. And so I think that it's important for us to make efforts to diversify the workforce, right? There are different questions that may be asked. There are different perspectives, right? And so we need more people of color, more people from different backgrounds in the healthcare workforce, and there are many efforts focused on that.
One of the things that Roche is doing is the Multiple Sclerosis Innovation Challenge, which is to drive real change towards providing early detection of MS, right? So that when you have those first signs, and maybe the doctor is, their healthcare provider might not be taking this person as seriously as they could. We're trying to put information out to enable early and efficient treatment, improve monitoring, prediction of the impact of the disease in people's lives. How do you think that this challenge, in the MS Innovation Challenge, can help contribute to improving the care of all MS patients and address some of these disparities?
Yeah, so this is really exciting work, Quita, because I think sometimes, you know that definition of insanity, doing the same thing and expecting different results. We have to begin to think outside of the box, right? MS in 2024 or 2025 is not the same as MS in 1993 when the first treatment became available. And so we really have to find unique ways to try to reach populations. I think there's really big potential for the use of our digital networks, for our AI, all kinds of, tools that we have available to us that we just have not utilized as well in the healthcare space, particularly as it relates to MS. And if there's anything we learned from the pandemic, is that there are lots of things we can do remotely that we said couldn't be done remotely. And so I'm really excited about the innovation challenge because we really want to focus on new ideas of ways to address these disparities. And I think that, there is a great potential, in looking at some of these solutions that will be widely applicable to many populations, particularly those that are underserved, right? Whether it is the rural populations or the ethnic minoritized groups. I think that, this could really be a game changer. And so I'm really excited about it.
All right, excellent. So, in closing, what excites you the most about the future of MS?
Well, this is an exciting time to be a neurologist and a neuroimmunologist. There is so much that has changed. My patients are doing so much better than they were doing, when I first came into this space. And what really makes me excited is that we certainly don't have a cure yet, but now that we have really good treatments, we can begin to focus on holistically treating patients. We can begin to focus on addressing these social determinants of health, looking at barriers to care. We can also look at, alternative and complementary medicine and integrative medicine and ways that we can really empower people to help themselves. And so I'm really excited, about the space. I'm excited about much of this work and also about looking at innovative ways to address some of these gaps in care. So, there is so much, that we have going on in the space. Sometimes it's almost a little hard to keep up. But those are just a few of the things that I'm really excited about.
Excellent. All right, last thing. If you could summarize this podcast in one sentence, what comes to mind?
What comes to mind is that we have to do something different to get different results.
Yeah, absolutely. Absolutely. Well, Dr. Williams, thank you for joining us today. And thank you for listening. Be sure to stay tuned for part 2, where Dr. Mitzi Williams will dive deeper into the Genentech Chime study. I can't wait to talk about that. What's missing in the MS space and how we can increase diversity and inclusion in multiple sclerosis research. Thank you all.